Welcome to ATCM, the Emergency Medicine Channel. So maybe
Yes.
the case. This is a case of a 53-year-old male who presents with 3-month history of difficulty in walking, a 3-month history of bilateral lower limb weakness, and 3-month history of tingling and numbness over his bilateral lower extremities. History of presenting illness: 3 months back, he was asymptomatic, following which he developed a febrile illness which lasted for 5 to 6 days. Associated with this febrile illness, he had a 2 to 3 day history of diarrhea, semi-solid watery, no mucus or pus, no other symptoms were noted, was treated with medications, to which he developed a acute rash, which didn't resolve completely once he stopped the medication. Then he later went to another hospital for the rash, where he was treated with antihistamines and other medications. Again, to these medications, which was unknown, he further developed another allergic reactions. At this time, he had no respiratory distress and no features of any lip swelling or any oral swelling. At this time, he noticed some progressive difficulty in walking, which was constant, and there was no associated worsening at night. And he also noticed the typical glove and stocking type of tingling sensations. He wasn't able to feel the ground. Felt like he was walking on cotton wool, and he couldn't hold his slippers properly. He had some difficulty buttoning and unbuttoning his shirt, and while taking food in his hands, he was not able to feel it. Then he came to India. He is actually based in Dubai as a driver for a mining company, where he was evaluated for his neurological syndrome at a outside hospital. Here he was found to have a isolated leukopenia on his CBC. So here he was further referred to another outside hospital because there was a lack of a hematologist available there. Here they had done bone marrow evaluation, which was suggestive of a MDS with low blasts and 30% of eosinophilia, for which he was treated with steroids, amitriptyline, and neuroprotective agents, following which he improved symptomatically and was discharged. On a follow-up, CBC done a week later, initial hematological derangements had resolved and the ESR was normal. So throughout all this, he was worsening neurologically. His difficulty in walking continued to progress. He had difficulty in getting up from a sitting position, worsening tingling and numbness, and he also had a drop in his functional status to a point where now he can only ambulate with support. At this point, there was no bowel bladder dysfunction, there was no band-like sensation, there was no shock-like sensations while flexing his leg, no altered mental status, loss of consciousness, seizure-like symptoms, personality changes, insomnia were noted. Thus, at this point, he was referred to AIIMS, our hospital, for further evaluation. Also, due to his bedridden status, bystanders had also complained that he has developed multiple bed sores.
Okay.
Then, other symptoms, review of symptoms, obstructive urinary symptoms were noted. He complains of some postural dizziness, but there was no history of any nocturnal diarrhea, no intolerance to light, no lack of sweating, no lack of tears. Some bloating-like symptoms were volunteered by him, and there is also a history of significant weight loss. Past medical history: he is a known case of type 2 diabetes mellitus for 8 years on alternative medicines and BPH. Social history: he is a driver by occupation, works for a mining company. He lives in Dubai. Occasional alcohol use present. This is his history, sir.
So what do you think from history?
So he is presenting with a chronic sensory syndrome, which had a distal to proximal evolution. So most likely the possibilities first would be a chronic inflammatory demyelinating polyneuropathy based on the syndrome of his presentation.
CIDP.
CIDP, sir.
CIDP.
Yes, sir.
CIDP at presentation, normally normal pattern, there will not be any sensory involvement. It is like AIDP only, but it is chronic process. Sensory involvement is only in few variants of CIDP or AIDP gets sensory involvement. Glove and stocking type of sensory loss is not at all a feature of CIDPs. They are features of peripheral neuropathy. Distal peripheral neuropathy, sensory nerves are involved. What are the common causes for distal, like this peripheral neuropathies?
So, most common cause would be diabetes.
So, he is a diabetic. One of the most common causes is diabetic peripheral neuropathy. That is a classical example for peripheral neuropathy. Second thing,
Diabetes, then alcohol use,
alcohol can produce peripheral neuropathy. Then
B12.
B12 deficiency, folic acid deficiency. These are the common causes. Since he is having diabetes, first differential diagnosis has to be diabetic peripheral neuropathy. They are all large fiber neuropathy. They can have distal glove and stocking type of sensory loss. Why this glove and stocking type of sensory loss occurring in all these conditions? Where it starts in the leg. Then once it reaches your knee joint, it starts in the upper limb also. That's why that pattern is like a glove and stocking.
Yes, sir. Length dependent.
It is all length dependent neuropathy. So larger nerves, like length is more in nerves, means that nerves will be affected first. Okay.
Yes, sir.
Okay.
Then moving on to his examination, vital signs: heart rate was 82 beats per minute regular, BP 110/17 right upper limb in supine position, saturation 98% in room air, respiratory rate 20 per minute.
If you are suspecting CIDP, how will you examine pulse and BP in this patient?
Ideally, you will have to do a postural
You have to always check for respiratory variation on the pulse. Okay. Respiratory variation in the BP. Postural drop in BP. All these things are very important when you are examining a suspect. You told it is a CIDP. That's why I am telling. Whenever there is a neuropathy or CIDP, it is always better to examine for the autonomic dysfunction in this patient. Autonomic dysfunction can be found out by your pulse examination in inspiration and expiration, BP examination, inspiration, expiration, postural drop in BP. All these things are very important. Sweating, that is explained already in your history. Okay.
Moving on to the systemic exam, general examination, he appears stated age and no respiratory distress. The examination of the head, ears, nose and throat revealed no pallor, no icterus, no cyanosis, and neck was supple. Cardiovascular examination, regular rhythm, S1, S2 normal intensity.
Tell about hair loss in this type of patients. Hair loss is very important. Okay. Recent history of hair loss, pattern of hair loss. All these things are important.
Okay, sir. Lungs clear to auscultation bilaterally, abdomen soft, non-tender. Moving on to the neurological examination.
Abdomen what will soft non-tender is only superficial examination. This type of cases, what all things you specifically look for?
Any
what all things you will specifically look for? All these cases, peripheral neuropathy, autonomic neuropathy. Why you are afraid about abdominal examination, heart examination? Vowel sounds are very important. These patients can very well have intestinal obstruction. Okay, so we have to examine properly. Since it's a postgraduate case, you have to examine in detail. Okay.
And neurological examination, he was alert and oriented.
Bladder is okay.
So
it's
no,
full.
Historically,
there is no issue.
No bladder, sir. No obvious cranial neuropathy. So moving on to the upper limb examination, bilateral tone was normal. Power was 5/5. Reflexes, biceps were 1+ bilaterally, sir. Okay. And vibration
Which are cranial nerves involved in peripheral neuropathy diseases?
Cranial nerves 3, 5, 7.
Okay. Strictly speaking, all cranial nerves are involved, but some cranial nerves are commonly involved in some types of peripheral neuropathy. What are the common peripheral nerves involved in or part of cranial nerves?
Cranial nerve 7 and GBS with bifacial.
GBS bifacial involvement can be there.
Cranial nerve 5 and certain infections like leprosy and all will infect.
Okay, that also can be involved.
Then
optic neuropathy is one of the commonly associated neuropathy along with all these like toxic neuropathies, B12 deficiency, folic acid, all this peripheral neuropathy other than age-related neuropathy. Optic nerve is one which is commonly involved. Diabetic patients, what type of third nerve cranial palsy you can get? What is the type of third cranial nerve palsy you get in diabetes? One of the common conditions where third nerve palsy is involved seen is diabetes. So what is a peculiar nature of third nerve palsy in diabetes? So that is sometimes called as surgical third nerve palsy and medical third nerve. Surgical is mainly seen in aneurysms and head trauma and all. So third nerve is one of the common cranial nerves involved in head trauma and aneurysms. But that is entirely different from third nerve palsy in diabetes. How it is different? That is a homework for you. That people will tell you, that people of eyes will tell you whether it is a third nerve palsy due to diabetes or due to aneurysms. That is called a surgical third nerve palsy and medical third nerve palsy. Medical third nerve palsy is classically is in diabetes. So people examination will tell you which type of third nerve palsy it is. Okay.
Then, sir, his vibration was lost below elbow, and his fine touch was also lost below elbow, and his proprioception was also lost below elbow.
Okay. So all all peripheral nerve examination modalities are reduced in
Below elbow.
distal below elbow.
And then no upper limb ataxia was noted, sir.
Okay.
Lower limb, no wasting was noted. No power was preserved on all joints. Toe grip was noted to be weak. Reflexes, ankle jerk and knee jerk were lost.
Okay.
And vibration and proprioception was also lost below knee, sir.
Okay.
And in this, there was no nerve thickenings.
Why deep tendon reflex are lost in peripheral neuropathy?
The nerves are...
Why it is lost? What is the mechanism? Can you tell about reflex arc? What is a reflex arc?
There is a...
Emergency medicine? No need. Reflex arc. Is not required? It is required. Deep tendon reflex are important part of CNS examination. So some patients, even when there is pyramidal tract involvement, you can have a very low deep tendon reflexes. That is because of peripheral neuropathy. Like yesterday we discussed about subacute combined degeneration. The spine is involved, but there is no deep tendon reflex there. That is because of peripheral neuropathy. To understand that, you should know about reflex arc. What is a reflex arc? What is it? Reflex arc. It's a basic physiology, no? What is a reflex arc? When I am examining knee reflex, what will happen?
Stretch will happen, so that will...
Stretch will happen. From there, the signal will go to spinal cord. The spinal cord will be activated. Another signal from spinal cord will come to this this joint, and that contracts the muscle. Okay. So there is an efferent, there is an afferent. Okay. Both are peripheral nerves. Okay. If one of the efferent or afferent is involved, that is peripheral neuropathy. Or if there is a problem at the center, okay, like compressive lesion at that level, all can damage the deep tendon reflex. So that's why in peripheral neuropathy, either afferent or efferent are involved, because it's a peripheral neuropathy, sensory or motor is involved. So you'll get an absent reflexes. Or sometimes there will be some compressive lesion in the spinal cord. That also can completely abolish the reflex. Okay, below that compression, you get all exaggerated reflexes. So here peripheral neuropathy, because of sensory roots are involved and there is no sensation carried from the joint. That's why you are not getting the exaggerated reflex. Okay. Yes, so for that you should know about reflex arc. So there are three components: afferent, center, afferent. Okay.
And sir, his gait and coordination, the gait, he wasn't able to walk, and he was having Romberg's was positive, sir.
Okay.
And moving on to the extremities and skin, he was found to have left axillary lymphadenopathy was present.
Okay.
And he had a grade 2 bedsore over his...
If there is an axillary, you are telling axillary.
Axillary lymph node.
Axillary lymph nodes. Where else you will examine? Axillary lymph node is only a peripheral sign of something. Where else you will examine?
Axillary, cervical, inguinal.
No, you are told axillary only.
Yes.
No other lymph nodes. So there is no point in telling that other side also. You are already examined. You found out that there is a lymph node in the left axilla. Where else you will examine for this patient?
It's on the abdomen and respiratory system.
Left axilla. From where it will drain? Left axilla or right axilla? Which side?
Left, sir.
Left. So where else? Where all you will look for the lesion? Axillary lymph nodes are not very common. So where all you look examine? He is a male or female?
He is a male, sir.
Male, and he is having peripheral neuropathy. What will immediately come to your mind if there is an axillary lymph node, peripheral neuropathy, elderly individual, as a medicine paraneoplastic syndrome. So where will you examine for that patient? You have to examine the breast. Immediately examine the breast. That is the first drainage site of that axillary node. Then if you want to take an X-ray, see the X-ray and see whether any pleural lesions, rib lesions, all these things. But if you are seeing an axillary lymph nodes, during examination, you have to always examine the breast of that patient, because he can have a breast mass variable. Okay.
So at the end of history,
These all suspicions. I am not telling this will be there. If you don't suspect, no, you will not make a diagnosis. Whatever you see, you have to suspect something, and along with that, you have to examine some other area and find out that whether it is there or not, plus or minus.
So at the end of the history and examination, our possibilities at this stage are CIDP. Either it could be related to diabetes, or it could be paraneoplastic, or in view of his exposure to alternative medicine, maybe it could
CIDP is entirely different spectrum of disease. Diabetic neuropathy is entirely different spectrum. Both are totally different. CIDP is a chronic inflammatory demyelinating condition, whereas diabetes is not like that. Okay. It is due to the lesion in the, where is the lesion in diabetic neuropathy? Microvascular. Vasa? Nervorum. There is a blood vessel to the nerve, to the nerve, that is damaged in diabetes. Okay, that is the reason for diabetic neuropathy. Whereas in CIDP, the reason is the covering of the nerve is affected. Both are entirely different spectrum. Okay, this is only demyelinating. Other one is there is a damage to the blood vessel and nerve is dying. Okay.
Based on that.
So don't tell CIDP as a differential diagnosis here, because glove and stocking type of sensory loss is always a large fiber neuropathy, especially in diabetic patient. It is due to diabetes. Some other chronic toxin, it is due to toxin induced neuropathy. Okay.
Okay, sir. Then moving on to his lab results. His basic initially CRP was 73. His RFT was within normal limits. Bilirubin was elevated at 3, and his AST and ALT were within normal limits. ALP was 138. Sodium was 116. Potassium 3.6. Calcium was 8.9. ESR was 44. And PT was 13.3 and INR was 0.9. White cell count was 12.4. Hemoglobin was 12. MCV was 84.4. Platelet count was 239,000.
HP is?
Sir, hemoglobin is 12, sir.
12. Okay. Sodium is low.
Sodium is low, sir.
Okay. So should we correct the sodium or not?
In this case, sir, he's not having any altered mental status or any seizures or any depression.
That doesn't mean that we should not correct it. We have to correct it. Whether you need a faster correction or slower correction, that is only the question. Should we correct it?
We should correct it slowly.
How to correct?
We can first send the evaluation like serum osmolality, urine osmolality, uric acid to see what kind of a hyponatremia.
What is the urine sodium in this patient?
The urine sodium was found to be normal, sir. It was 12.
Okay, so then what is your diagnosis? Elderly individual who is bedridden, his sodium is low, urine sodium is normal. What is your diagnosis?
Poor oral intake.
Oral intake, depletional hyponatremia. That you give oral salt, it will improve.
Yes, sir.
Okay.
Then to
can we give 3% saline for this patient in emergency room? Yes or no?
No.
Why?
If the patient is not asymptomatic.
Yes, if the patient is not symptomatic, we don't require IV. This one. Suppose we give IV and if it is a little faster rate, what will happen?
Pontine demyelination.
Pontine demyelination. Okay. What are the demyelination syndromes you know?
Osmotic demyelination.
Osmotic demyelination, there are two types. What are the two types?
Pontine
Central,
myelinosis.
pontine and extra pontine. Okay, pontine is pons is involved. Extra pontine means other than pons is involved. Pons is involved means patient will be in a locked in state. Whereas other areas are involved, patient can have encephalopathy, altered behavior, all these things. Okay.
So then we went ahead with an ultrasound of the axilla, which revealed 3 to 4 axillary lymph nodes with preserved fatty alum in the left axilla, measuring 38 into 8.5 millimeters.
Okay.
And then because
So
we
did
had
you
a
try for a
suspicion-
FNIC from that?
No, it's FNAC we didn't try. We went with tumor markers and PET CT evaluation.
Okay.
So the tumor markers PSA, CA19-9 AFP and CA were all within normal limits, and the whole body PET CT just showed a non-metabolically active soft tissue mass involving the upper pole of the left kidney, which was suspicious for malignancy.
Okay.
No evidence of metabolically active disease elsewhere.
Okay.
And because we also wanted to evaluate his to look for an autoimmune etiology also.
Okay.
Basic ANA immunofluorescence was done, which was negative. ANCA serology was negative, and anti-MP and anti-PR3 antibodies were within normal.
What is the type of small vessel disease? Small vessel vasculitis is it is the only vasculitis which will be common in elderly individual. What investigation you do for these patients? What will be there in your mind when you are investigating these type of cases?
Small vessel vasculitis can be broken down into pauci-immune and immune complex.
Okay.
And for pauci-immune, you will have to look at the ANCA serologies.
Okay.
For immune complex, you will have to send C3, C4 also.
Okay.
Can be classically seen in,
What will happen to C3,
it
C4?
will be reduced, sir.
Reduced.
Then some certain other forms like cryoglobulinemia can also cause a small vessel vasculitis.
If it is positive, then what viral disease you will suspect?
Hep C, Hep B.
Okay. So these are the basic investigations you have to do. But okay, continue.
Yes, sir. So the autoimmune etiology was, so we had the disease process in mind by paraneoplastic versus autoimmune, and because of his significant exposure history, we also thought could it be toxin related.
Okay.
So then
What exposure he had?
he had the alternative medicine
Alternative
for type 2 diabetes mellitus.
What are the common ingredients of some of the alternative medicines what we come across here? Common ingredients which is added.
Lead, sir, arsenic.
Lead and arsenic. Okay.
So we sent the serum and like heavy metal panel. The urine arsenic came out to be greater than 1000 mcg per liter.
Okay.
The normal cutoff is actually less than 50.
Okay.
So the serum arsenic which we had sent, sir, was about 23.79 mcg per liter. Our reference range was 0 to 11.9.
Okay.
So both
Serum is lower, but urine is very high.
Very high,
What is the reason for that?
chronic exposure.
Chronic exposure, and the serum will remain in the body for only very short period. It will be removed through urine, and it will persist in the urine for a longer time, and even it can persist in your hair and nail for longer period. Okay.
So because of this, we got our diagnosis as a heavy metal. That was a possibility. For completion's sake, we did a CSF study also, sir.
Okay.
The CSF showed a glucose of 119, protein of 104 with no cells.
Okay.
Infectious workup on the CSF was negative, sir.
Okay.
And then nerve conduction study was also done, which revealed a demyelinating polyneuropathy affecting both upper and lower limbs.
Okay.
Then the toxicology panel, actually then we had started him on, because the NCV was showing a demyelinating picture, we had started him on pulse dose steroids.
Okay.
Methylprednisolone 1
So
gram.
that doesn't correlate with diabetic neuropathy.
Yes, sir.
It is only heavy metal poisoning. Okay.
Yes, sir. So then we started him on pulse dose steroids, which was given for 3 days. Then physiotherapy. We
Is
also
he having a foot drop?
Foot drop wasn't there, sir. But mainly the vibration and proprioception was lost.
Okay. Because most of these heavy metals will have both types of neuropathy. They have not axon. They have sensory and motor. Sensory, like you told, all vibration sense, everything will be lost. Motor, they present with foot drop. Okay.
Physiotherapy, we initiated him on physiotherapy. Serum arsenic was repeated on the day of discharge, and that was again came out to be 19.
Okay, it is coming down.
Coming down, sir. Okay. And then the plan was to review after 1 week, and if serum arsenic levels were still high, and if his neurological symptoms were still persisting, to plan for chelation therapy.
Okay. So what are the common chelation therapies you advise for the patient?
Actually, here we use BAL, so British anti-leucide.
Okay.
Dimer Captol, 3
okay.
to 4 mg per kg until the urine levels become less than 50 micrograms per liter.
Okay. Any role for dialysis?
Sir, if they're present with acute symptoms like
renal failure
renal
and
failure,
encephalopathy and all, there is a role. Otherwise, chronic symptoms, there is no role. And if you give, suppose if these things are not available, we have to give little more time. Patient will naturally recover, but we will not know what will happen to the damaged nerve. It may come back to normal, or sometimes there will be permanent damage to the nerve. Okay.
Yes, so then again his repeat was found out to be 19. Then again he followed up with us. He came to the OPD with worsening of neurological symptoms, difficulty standing, again even with support, and buckling of knees while standing.
Okay.
So from our side, then we wanted to plan him for a chelation, trial of chelation, but then he was lost to follow up, sir.
Okay.
So last thing, we had just given him again methylprednisolone 500 mg stat dose, and asked him to come and repeat it like 500 mg once weekly for 2 months, which is the treatment for CIDP.
Okay.
But he was lost to follow up, sir. So we don't know what happened to him after this.
Anything else you want to add?
So just the treatment of the toxicity, like acute phases, we have to treat with dialysis. Otherwise, chronic phase, chelation is sufficient.
Okay. Steroids are not good choice in lead poisoning and arsenic poisoning, because we know what is the reason for that. It is not an inflammatory problem. It is a like a destructive problem. So steroids may not be very useful in that. Anything else you want to add? Okay.
Thank you, sir.